Bonjour tout le monde.
Salut Damien.
Hey.
Bonjour Damien. So we start. Dear colleagues, dear friends, it's my pleasure to welcome you for this new webinar organized by the ENS school-based section. This webinar is a little special. This webinar is dedicated to our mentor, Professor Bernard Georges. Probably most of you know that our mentor passed away a few weeks ago. So it's an honor for us. We are 7 of his pupils to share with you what we have learned while working with him. It's a special webinar dedicated especially for him. I will share my screen. So we are 7 to speak this afternoon. We have Radboud Coat from the Netherlands. I will then speak. Then Cédric Barret from Lyon, Jan-Frédéric Cornelius from Düsseldorf, Germany, Oscar Alves from Porto, Portugal, Damien Bresson from Paris, and then Sébastien Fröhlich, who take this position in Lariboisière Hospital, of course, as you know. So the history and the career of our mentor, Professor Bernard Georges, can definitely not be dissociated from Lariboisière Hospital, where he spent all his career. It can also not be dissociated from the vertebral artery. He developed this field. He writes a lot of paper and 2 books dedicated to the vertebral artery. The first book with Claude Lorient in 1987, and then the second book that he published in 2011, a book of 700 pages dedicated uniquely to the vertebral artery management. During his incredible career, he received many awards. One of these awards was especially important for him. It was the award given in Stockholm, the Olivier Crona Award, what he called the Nobel Prize of surgery. He received that around 15 years ago, and of course on the vertebral artery topic. He received also a career award from the ENS during the ENS Congress in 2018. Bernard Georges was an incredible surgeon. He was also an incredible man. We can name him as a master, a mentor, a friend. What is the difference? A master is someone like him who is able to manage difficult patients, that is able to show you how to handle incredible difficulties around the vertebral artery, but also in other topics. But more than a master, it's also a mentor. It is someone with this special relations making that you would like to follow him in his practice, but also at some point in his life. This is the difference between a master and a mentor. And finally, a friend, when beyond the scope of neurosurgery, you are sharing with someone, and especially with him, some personal things of your life and your own personal development. So he was, for most of us, I think, a master, a mentor, and also a friend. As for, I think, most of you, because most of you have had the opportunity to know him during congresses and outside the congresses, and maybe you have observed the different parts of his personality. We have his pupils make a turn among us to define some words that can be applied to define Professor Georges. One word comes often, which is visionary. Professor Georges was a visionary. He was perfectionist. He has, of course, incredible faculties, memory faculty, were incredible besides his, of course, surgical techniques. As a mentor, he was dedicated to his patients. It's why we would like to follow him. He was a true teacher, and he will never give up before reaching the goal. It was also one of his characteristics. He was rigorous and meticulous with special attention to details. He wants to achieve a perfect result, and what was also characteristic, every gesture has a meaning. He never made a gesture more than once. It was incredible to see him while operating, directly targeting the goal, one gest, one consequence, the perfect consequence. Never it bleeds. He had a plan that he put into action as he began to operate, characteristically. He was very demanding of oneself and the people around him, of course. As a man and doctor with the big heart for his patient, he was also attentive to his troops. Definitely, he defended his troop as well. His life's motto was work hard and party, but also play hard, meaning always in the extremes. I will then share with you the tips and tricks how to operate some vertebral artery tumors. But first of all, the first talk will be given by Dr. Coat, working in the Netherlands, on how to prepare when dealing with a cervical approach, a cervical tumor. Please, Radboud, up to you. I will stop to share my screen.
Okay. Okay, thank you very much. I will share my screen. So when I arrived in Paris, Hôpital Lariboisière, at the end of 2002, I was honored to have the opportunity to take part of the team of Professor Bernard George. I stayed for over a year and saw patients with incredible pathology around the cranio-vertebral junction, coming from all over the world to be treated by Professor George. The atmosphere was incredibly stimulating, working hard with high adrenaline, but also relaxing moments, celebrating the efforts and results that have been achieved. Professor Bernard George was proud and good for his team. The team was very loyal and supported him in achieving the astonishing impressive results in cranial-based surgery. After returning to the Netherlands, the pathologies around the cranio-vertebral junction were much less frequent seen compared to Paris. However, now and then we were faced with residual skull-based tumors after transoral or transnasal approaches. As you can see, for example, on this slide, mostly chordomas, suitable to remove by an anterolateral approach. But so how to prepare for this anterolateral approach? So first of all, you need to have the right imaging, MRI, CT scan, CT angiography, and you have to consider stability after resection. Then you study the anatomy of the V3 segment, as is shown in detail in this slide. Then you check the book written by Professor Bernard George and Michael Bruno and Spetzler. You check chapter 25. And then, if possible, and you have time, you try to do a cadaveric dissection if you're not very frequently in this pathology. And then what I always do is you watch part of the video of for the anterolateral approach made by Professor Alan Crockett and Bernard George for the ANS course in Nice in 2000. And I will show you a part of this video.
What we'd like to show you today is the importance of the vertebral artery as the key anatomical structure for safe exposures of the craniovertebral junction. Basically, I think, Bernard, you would agree that if we know where it is, it doesn't matter whether we're going from the front or the side or the back. If we know where it is, we will be safe. It is also the way that tells us how to get to the pathology that we're interested in.
We're going to start by looking at the lateral approach to this region. And Bernard and Guillaume are going to take us through a prosection they have done on cadaveric material at the college.
If we were doing a lateral approach, the patient's lying on their back with the head tilted over, as you've shown here. You've done the skin incision before, just to speed things up. Tell us a bit about this lateral approach.
Okay, the skin incision is following the medial edge of the sternomastoid muscle. You can see the sternomastoid muscle here, up to the tip of the mastoid process, then on the mastoid process, then more or less extended along the superior occipital line for 3 centimeters in this case. Repeat.
So, Bernard, we've got the mastoid disconnected from the sternomastoid muscle. The sternomastoid has gone back. Now, please, are there things that we must identify, things to avoid, which will allow us a safe passage?
Okay, this is a natural field. The field is limited by the lateral side of the jugular vein, the medial aspect of the sternomastoid muscle, and we are going to work in between these two elements. And the only structures which crosses this field is the accessory nerve. This is it. This nerve comes out from the jugular foramen to join the medial aspect of the sternomastoid muscle. It must be identified. It must be separate from the depths of this field. It must be separate from the jugular vein. And what is around this nerve is this sheet of fat and lymphatic elements that must be dissected away from the nerve, and then it can be used to protect the nerve during the retraction of the nerve like this.
I see, that's very useful. If we were looking at the whole head and neck, it's almost opposite the lower border of the mandible. Is that about right?
Absolutely.
So that's the sort of area that we want to be picking it up, shall we say, on the sternomastoid, and then working upwards and medially to find the nerve as it comes out from the head. And that's I must say, I think that's a wonderful tip of using that fibrofatty layer over the nerve. I haven't seen that before. I think that's a very, very nice trick. Can I just ask you, you've shown us the carotid artery and the jugular here. We've taken this back. What's this structure here? We seem to be down.
Okay, well, at the depths, in the depths of this field between the jugular vein and the sternomastoid is the prevertebral muscle. That means the longus colli medially and the anterior rectus laterally. And there is an aponeurosis covering this muscle, of course, and running under this aponeurosis, I guess you can see that on the videos, is the sympathetic chain, which is something obviously that has to be preserved before 5.
So let's go further up again. Let's move up a little bit and show us what you see now.
Okay, if you take with your finger the tip of the mastoid process, and then you move down 10 millimeters in front and lower, and you reach the tip of the transverse process of C1. Just above is a muscle attached from the mastoid groove here, which is the digastric muscle. And then under this muscle, you have the tip of the transverse process of atlas. And from this transverse process of atlas are little muscle attached to it that you can detach to expose now the loop of the vertebral artery, I mean the suboccipital segment from C2 to the foramen magnum.
And what happens when we remove those? Let show us what's underneath.
Okay, so we detach this muscle. It has been done previously. And we retract laterally this muscle. We put them under the retractor. Even we can take the digastric muscle on the other side. Be careful with the facial nerve, which is medial to this muscle. And then when you have cut this muscle, you have the two segments of the suboccipital portion of the vertebral artery, which is C2 to C1 and above C1 segment of the vertebral artery. This is the vertebral artery between C1 and C2. This is the vertebral artery above C1 in the groove of the posterior arch of atlas. Here you see this groove. You have the jugular vein, the accessory nerve, then the transverse process of C2, then the vertebral artery running between C2 and C1. And this is a very nice landmark in the approach of this segment of the vertebral artery. That's the second cervical nerve root, which crosses the vertebral artery. It appears in front of the vertebral artery in this position, but it runs obviously behind the vertebral artery. Then you have the posterior arch of atlas with the groove of the vertebral artery above C1. So here, between C1, C2 segment above C1 is the transverse foramen of atlas, in which the vertebral artery is passing by, and then it runs above the arch of atlas, then it leaves the groove of the posterior arch of atlas to reach the dura on the foramen magnum.
Bernard, now that you've taken the prosection for the lateral approach further in and exposed the vertebral artery with even greater clarity, take us some of the anatomy. What's that articulation that I'm seeing, which is being crossed by the vertebral artery?
To see this articulation you're mentioning, which is C1, C2 joint, of course, we have to transpose the vertebral artery. And this is what we have done. You remember, this is C1, C2 segment. Here was the transverse process of atlas, then the above C1 segment. Keeping out still of the periosteal sheath and the venous plexus, we have opened the transverse foramen. We have split the vertebral artery out of the foramen and then mobilized the vertebral artery like this, down. And now what you can see is what is remaining of the posterior arch of atlas. This is the depth of the foramen of atlas. This is the groove above C1. And in front of you, you have this joint, C1, C2. And maybe, Guillaume, you can mobilize the head, rotate the head. You will see this joint moving. Yes, back. Yes.
Isn't that beautiful?
Again, Guillaume. Yes. You remember the C2 root crossing the vertebral artery? This is C2.
You've divided it there, haven't you?
Yes, I have divided, separated from the vertebral artery until you see the C2 root. And if you follow this C2 root in the depths, we join the dura. And here we are at the junction between the root and the dural sac. And we can even work behind the C1, C2 joint in front of the dural sac. That means going towards the odontoid process. If I transpose the vertebral artery, I have a free space to go in front of the dural sac at the level of C0, C1, C2.
So after having seen this video the night before, well, we think we are ready, the best prepared to do the operation. So by transposing this anatomical knowledge, by transposing his anatomical knowledge of the vertebral artery and his very structured operative approach to the craniovertebral junction into a didactic format, if you know where it is, Professor George has played and will be playing a major role in the formation of young neurosurgeons, including myself, and in the progression of neurosurgery in general. Regarding myself, I had a great time in Paris, and I think it has been very important in my career. I thank Professor George also for keeping in contact with us the last years, and I hand over to my friends speakers. Thank you for your attention.
Thank you so much, Redboat. As you remember, I had the chance to follow you in Paris in 2003. And of course, the chance to work with Bernanrd. I learned many things in contact with him. And I will discuss this afternoon with you the tips and tricks to deal with complex cervical tumors. Everything that is in my presentation now comes from what I learned from him, definitely. So what kind of tumors can be treated and are in close relation with the vertebral artery requiring its management? A lot of soft tissue tumor. This is a vagus nerve schwannoma. This is a dermoid tumor. This is a liposarcoma. There are also bone tumors, many kind of bone tumors, primary tumors, but also metastasis. And what was also interesting when working with Professor Georges was his management of extramedullary tumors, and I will give you his philosophy when dealing with such tumors. What I learned from him, the first thing, the basic thing, is the anatomy of the vertebral artery. And the anatomy is quite special. The vertebral artery is subdivided into 4 segments. The first segment is called the V1 or ostial segment, running from the subclavian artery up to the C6 transverse foramen. Then the vertebral artery runs into the foramen from C6 to C1. From C6 to C2, it is called the transversalis segment. From C2 to the dura mater, turning around C1, it is the V3 segment or suboccipital segment, and then followed by the V4 intradural segment. I put V1 and V4 in red and V2 and V3 in blue because in V2 and V3 are in fact surrounded by a periosteal sheet. Between C6 and the dura mater, there is a periosteal sheet surrounding the vertebral artery, and it has some implication to deal with the vertebral artery during such procedure. First of all, the vertebral artery is protected by the sheet itself, but some bleeding can appear from the plexus surrounding the vertebral artery, and for this reason, the exposure of the vertebral artery has to be properly done, systematically done. You see here a surgical view. You can see V1 unprotected compared to V2 by a periosteal sheet, and inside the periosteal, the surrounding veins. You can see here the vertebral vein following the vertebral plexus down to the subclavian vein. Regarding the normal anatomy from the cervical vertebral artery, you can see here the anterospinal artery, and you can see at each level a metameric distribution of muscular branches. When you are operating a tumor in close relation with the vertebral artery, you have to know if you are facing a dominant vertebral artery or a non-dominant vertebral artery, because in many cases there is a difference in size between both vertebral arteries, and it is of course it is extremely relevant before operating such patients. When a vertebral artery is smaller, it is in fact associated with 2 conditions. Either the vertebral artery fused with the contralateral one, and it is called an hypoplastic vertebral artery. In such cases, it is not too dangerous to operate on this side because there is a contralateral compensation that is possible. But the vertebral artery, when of small size, can also be different, ending by the pica, and then it is named an atretic vertebral artery. It's absolutely not the same condition because the vertebral artery cannot be sacrificed. It's a terminal supply to the posterior fossa circulation, and then if you divide the vertebral artery, you can not spare the vertebral artery, then the patient will suffer from a thrombotic event. In contact with Professor Georges, I learned many anatomical variations, and he has an incredible bibliography of many variations in the origin of the vertebral artery, quite rare, and most of the time not relevant for surgical vertebral artery exposure. But more relevant variations are located at the level of V2. You can face loops. You can also face abnormal level of entrance. Those are crucial to detect preoperatively in order to avoid any intraoperative problem. That it was a study that we made with Professor John in 2005, looking at the different trajectories of the vertebral artery on 500 patients. What we noted is that most of the time, as you know, the vertebral artery entered the C6 transverse foramen. It was in 93% of the cases, just as in these cases. You can observe that on basic MRI sagittal slide, you can see the trajectory of the vertebral artery as soon as you look for the vertebral artery. In 5% of the cases, the vertebral artery enters C5, which is problematic when you expose the vertebral artery. In 1% in C4. Less problematic is when the vertebral artery enters the C7 transverse foramen. It is in 0.8%. In this situation, the vertebral artery is protected since C7, so it's not truly relevant. But you have to know that because if the vertebral artery enters above C6, the vertebral artery is in front of the transverse process. In this situation on the right side, in this situation on an angio CT on the left side. So it means that the vertebral artery is not protected by the bone inside the foramen, but is in front of the bone. And it implies that when you divide the longus colli muscle, if you don't know that the vertebral artery is not protected by the bone, but is in front, you can injure the vertebral artery and have some problems during the surgery. But as soon as you have detected that preoperatively, there are absolutely no problem to expose the vertebral artery. The other anatomical variation at the level of V2 is the presence of loop. You can have corporeal loops or foraminal loops. Corporeal loop, such as in this case, you see when you comes from caudal to cranial direction, you see the loop that is formed in the vertebral body. It means that if you make a basic corporectomy and you drill here, you will injure the vertebral artery if you have not the knowledge of this situation. Exactly the same, but at the foraminal level. In 0.8% of the cases, there is a foraminal loop of the vertebral artery inside the foramen. If you treat a disc herniation, you are not aware of this situation, you can injure the vertebral artery. So if you do any kind of surgery at the cervical level, just have a look at the position of the vertebral artery. This is a CT scan, this is a classic MRI. You can perfectly know where is located the vertebral artery without incredible investigations. This is a reconstruction on angio-MR. You can also face lateral loops, and you can see how this vertebral artery is displaced by osteoarthritis. You see the foraminal stenosis, and I have found some patients with complete occlusion of the vertebral artery in relation to ankylodiscartrosis. You can observe that on a basic CT scan in bone windows. What I learned also from Professor George when dealing with vertebral tumor in relation with the vertebral artery is when to perform a balloon occlusion test. The first thing is to know which kind of vertebral artery you are facing. If you are facing a minor vertebral artery, just exclude the termination into a pica, that's enough. If you have a dominant or an equivalent vertebral artery compared to the contralateral side, you have to evaluate the risk of vertebral artery injury. Most of the time, the risk is low and you have nothing to do. The risk is higher when there is severe vertebral artery compression, encasement of the vertebral artery, if you have a malignant tumor to treat, if the patient has already been irradiated, and if the patient has already been operated on. In those 5 criteria, Professor George was asking a balloon occlusion test. His favorite approach to the vertebral artery was, as you have seen in the video, the anterolateral approach at the level of the cranio-cervical junction. It is in fact the same approach at the cervical level, the lateral approach. The lateral approach, as you have seen on the video, opened the space medially to the sternocleidomastoid muscle, but contrarily to the anterior approach, the approach is made laterally to the vessel. Then you target the longus colli muscle and the transverse process. This is the opening that you get at the end of the exposure, direct exposure to the vertebral artery. So the incision is made along the medial border of the sternocleidomastoid muscle. You have to divide, if you would like to expose the C6, C7 level, the homohyoid muscle. Then what I learned from Professor Georges was this coagulation section techniques. When you see Professor Georges operating on, you never see any bleeding. Why? Because he coagulates before dividing any structure. So he holds in his left hand a forceps, in his right hand the scissor. He takes the tissue, the assistant coagulate on the pincet, and then he divides. So the work was always in a perfect surgical field. What I learned from him to expose the vertebral artery and deal with the tumor, first, you have to reach areas where the vertebral artery is protected by bone, which is a transverse process. Then you have to perform a superficial dissection. And there are some tips and tricks to obtain bleeding control. And of course, when dealing with the tumor, you have to obtain first proximal and distal vertebral artery control above and below the tumor. If you would like to approach the vertebral artery, you have to divide the longus colli muscle. You have to know that the vertebral artery is not, has not an abnormal trajectory. You have to find the transverse process. You can touch it with your finger, it's a bone structure. Then you divide the longus colli above the muscle. If you divide the longus colli above the muscle, then you are sure that you will not injure the vertebral artery. Then you perform, when you reach the bone, you perform a superficial dissection, especially if you expose the vertebral artery between C1 and C6. As I told you before, there is a surrounding periosteal sheet. And then if you doesn't want to open the venous plexus, and because the periosteum is in fact in continuity with the periosteal sheet of the vertebral artery, you have to divide the periosteum, dissect with a spatula the periosteum to elevate the periosteum from the other side of the bone, but also the inner side of the bone. And then you can use a Kerrison Ranger. If you start directly with the Kerrison Ranger, you injure the periosteal sheet, you injure the venous plexus, and it starts to bleed, and it's a profuse bleeding. As soon as you do that, it's incredible, no bleeding at all. If you are facing some bleeding, you can apply on the sheet of the vertebral artery of the periosteal sheet, you can apply direct coagulation or packed with small resorbable sponge. This is such a tumor that can be treated, difficult tumor, soft tissue tumor extending in the foramen, but also in the canal. And you see how you can expose the vertebral artery from above to below and work laterally to the vertebral artery, then medially to the vertebral artery. You can open the dura and have a complete resection at the end of the procedure. This is another tumor. You have to concern, as I told you before, in tumor completely encircling the vertebral artery in a patient previously operated on, you have to consider to perform a balloon occlusion test, especially when the tumor is facing a dominant vertebral artery. If the balloon occlusion test is not tolerated and the vertebral artery cannot be spared, such as in this case, you have to perform a bypass. This is another case of tumor completely encircled by completely encircling the vertebral artery, hypervascularized tumor, and then you can expose the tumor with the lateral approach, then turn the patient and perform a posterior approach to completely resect the lesion. Those image comes from Bernard Georges. This is an osteoid osteoma arising in the pedicule and the facet. Most of the surgeons will approach posteriorly, will destruct the facet, and then the patient will either have an instability or require fixation. Professor Georges at that time made a lateral approach, mobilization of the vertebral artery, and selective resection of the osteoid osteoma, making the surgery less aggressive without any need for stabilization. He was one of his favorite topic also, as I told you, was the intra-extradural medullary tumor. When you are facing an intradural schwannoma, no doubt you have to perform a posterior approach. The question is different while you are facing a dumbbell-shaped tumor, and there are several kinds of tumor, dumbbell-shaped tumor extending more or less towards the canal, more or less intradurally. If you perform a posterior approach, you will have to perform a facetectomy. It will mean the postoperative instability. On the other hand, if you perform a lateral approach, you will have the possibility to treat the extra canal compartment, the foraminal, but also the intracanalar compartment, extra or intradural, without the need to perform a facetectomy. You can early devascularize the lesion, you have a perfect vascular control, and you are able to perform a complete resection. This is such cases with incredible extra canalar extension, extending in the foramen and in the canal. You see how it looks at surgery, a lateral approach. The tumor is here, open, debulked. You see here now the control of the vertebral artery, resection of the longus colli muscle, superficial dissection, exposure of the vertebral artery. You see here the vertebral artery completely displaced by the tumor. Then you are able to resect the tumor going posterior to the vertebral artery. And if you need, you slightly drill the bone medially to the vertebral artery, and you have a possibility to resect through this channel the intracanalar compartment through the medial and lateral aspect of the vertebral artery. If you are not doing that, this is a patient who was sent to me after a posterior approach and incomplete resection. You have no control of the vertebral artery, and many surgeons, of course, are reluctant to approach the vertebral artery from the posterior side without control. So the patient has pain, instability, and because the remnant was evolving, was operated onto a lateral approach. You see the superficial dissection, the opening of the foramen, you see the vertebral artery, you see the pathological C3 nerve root, and then the vertebral artery, the opening of the nerve sheath, the resection of the tumor, complete resection. At the CRANIO-CERVICAL junction, Radboud Code already explained what is the technique. It allows to reach extradural lesions, intradural lesions, and it is also an approach to the juxtacondylar, approach to the jugular foramen. Some very important technical aspect already detailed. When the patient turns the head, both segments of the vertebral artery below C1 and above C1 are moving. And as much as the turn is head, as much both segments becomes more and more parallel. If the patient is straight, then both segments are perpendicular. You have to know that when operating a patient at the CRANIO-CERVICAL junction, you have to know the anatomical relation because it changes according to the position of the patient. Again, some important anatomical variation I learned from Professor Georges are the variation of the pica, present in 5 to 20% of the cases, with the pica that comes from C1 above the atlas posterior arch, but also from C1, C2 vertebral artery. Some very rare malformation I have see with Professor Georges, fenestration, very rare, when the vertebral artery has two channels inside the periosteal sheath, but also duplication when in fact there are two vertebral arteries, one entering C1, C2, and one which has the correct trajectory. I will not go back to the anterolateral approach, nicely illustrated in the previous discussion. Just one thing, Professor Georges has incredible experience in chordoma. Sebastian Fröhlich will speak about that with you. This is such kind of lesions located at the sample C2, C3 level that can be treated while exposing the vertebral artery efficiently. If I am able to do that now, it's thanks to Professor Georges. Thank you so much, Professor Georges. We are many around you during this course, but since a long time. And all the time we spend with you and that you spend also with the youngs, you were dedicated to teach us, to teach everybody. And it was for me truly a chance to work with you. Thank you. I will stop to share my screen and maybe propose to Cédric Barret to follow with some cases.
So thank you, Michael. Good day, everyone. It's my great pleasure and honor to participate to this special webinar dedicated to Professor Georges, with the willingness to pay a scientific tribute to him. And great thanks to Michael for taking the initiative of this event and organizing the conference. So as you know, Professor Georges chaired the neurosurgical department at Larry Brazier Hospital during nearly 20 years, from 1997 to 2014. And personally, I had the opportunity to visit his institution in 2003 for half a year. And at that time, the neurosurgical department was on the left part of the building. I think it is still the case. And my co-fellows were Yann Cornelius, Damien Bresson, and Antoine Dinicher. As a spine surgeon, I was really interested to get benefit from the huge experience of Professor Georges regarding the complex cervical spine surgery, and especially management of C1, C2 tumors, cervical chordoma, vertebral artery surgery, occipitocervical disease, and most of other pathology around the upper cervical spine. And I was really interested as a spine surgeon, and that was a point that Professor Georges could be captivating for not just the school-based surgeon, but also for spine surgeon. Last time I could see him physically, it was at the vertebral artery course organized by Michael in 2018 in Liège, and there was a really friendly and convivial atmosphere. It was very fun, and most of his alumni were present. Sébastien, of course, Oscar, Yann, Michael, Damien, Mounet, Peter also. It was really a great moment, and it was fascinating to see how Professor Georges, despite the illness, was still a leader and a mentor. So now I would like to share with you some clinical cases around the vertebral artery. And I would like to start with this case. In fact, it is the first case I performed in Lyon after my return from Larry Brazier, performing the lateral approach. So it was a huge cervical chordoma. You can see on the MRI from C2 to C5. And the case was operated with a carmine motolese. And we realized a complete resection through the lateral retrojugular pre-sternocleidoid mastoid approach with exposure of all the neurovascular structures. And at the end, complete resection of the huge tumor. And the case was published in a GNS. And I think it was the first time that the lateral approach, as codified by Bernard Georges, was achieved in Lyon to resect a cervical chordoma. Another case operated by Professor Georges and published in Neurosurgery as a technical case report. It's an interesting case. It was a rare dumbbell hemangioblastoma in the cervical spine, C5, C6, close to the vertebral artery. The case was interesting regarding the angiographic theater and characteristic. As you can see, with hypervascularity, early venous drainage, and enlarged and tortuous vein. And the case was treated via lateral approach, as you can see. So this is the intraoperative view. After exposure of the vertebral artery, the extra-spinal component of the tumor was observed. First step was devascularization with control of the feeding arteries, as Michael explained, and then by walking under and medial to the vertebral artery, it was possible to progressively remove the tumor, including also the intradural component. The next case is a foramen magnum meningioma, probably one of the favorite pathology of Professor George. I know that Oscar will speak about that later. So I will show you the case briefly. So the meningioma was exposed through a standard midline posterior approach. You may observe that the meningioma surround the vertebral artery on each side, mostly on the right, with strong adherence between the tumor and the artery, as you can see on the right. And progressively, after controlling the proximal and distal segment of the vertebral artery infradural, it was possible to detach the tumor all around the vertebral artery. And so at the end, although the important extension of the tumor, it was possible to resect totally macroscopically this meningioma. Next case I would like to share with you is C1, C2 metastasis. The case was discussed 2 years ago approximately with Professor George. So I communicate with him about the strategy. So I'm pleased to share the case with you. The case, is a male, 58 years old, primary thyroid cancer with 2 cervical metastases in the upper cervical spine. You may observe the location at C1 on the right part of the vertebra, involving the lateral mass and in close contact with the vertebral artery and the internal carotid artery. And this is the location at C2 on the posterior arch, penetrating into the canal and coming in contact with the spinal cord with compression. So regarding the relation between the arteries and the tumor, we decided to perform preoperatively an angiography with occlusion test, as discussed by Michael, and embolization also, regarding the hypervascularity of the lesion. And finally, the case was treated by combined surgery. First, a lateral retrojugular approach was achieved to resect completely the C1 location, as you may observe on the post-op CT scan. And then a posterior approach was realized, permitted to resect the C2 posterior mass and stabilize adequately the upper cervical spine with occipital C4 fixation. And lastly, I would like to end my presentation with a complex cervical deformity case. It was not the favor of Professor George, but I think the technical points permit to now realize that kind of surgery. So the case is a male, 52 years old, still active, working as a French and Latin teacher. The patient presents an history of cervical injury at the age of 12 with 3 surgeries between the age of 12 and 18. And after that, he developed progressively a major kyphotic deformity at the cervicothoracic junction and with major chronic axial neck pain. So standing radiograph demonstrate the importance and the severity of the spinal deformity, as you can see. The thoracolumbar spine was lordotic up to T3. The cervical spine was kyphotic with more than 90 degrees of kyphosis between C3 and T2, with compensation in the upper cervical spine and hyperextension between C0 and C2. And of course, all the sagittal parameters were completely disturbed, and you may observe the T1 slope oriented posteriorly with a posterior inclination of T1 slope around 25 degrees. So this is the CT scan showing the completely fused C3 to T2 segment with a complete fusion anteriorly and posteriorly and adjacent degeneration of the upper cervical spine and cervicothoracic junction. Regarding the soft tissue, the spinal cord was rather fine with no atrophy, as you may observe on the MRI, and no hypersignal. And the vertebral artery penetrates the cervical spine at C6, but circulates inside a completely ossified bony channel along the fused segment. So that was the case, major rigid kyphotic deformity. The plan was to perform an osteotomy, tricolon osteotomy at C7, kind of tricolon osteotomy with the aim to partially correct the deformity. So finally, we did the plan. So tricolon osteotomy was achieved at C7 with long posterior fixation from C2 to T4, with partial correction of the deformity, residual kyphosis around 50 degrees, and a gain of correction around 40 degrees. And as you can see on the full spine, a more harmonious spine and more harmonious spinal curves. Unfortunately, the point and the concern was the occurrence of an injury of the left vertebral artery during the surgery. Intraoperative bleeding could be controlled easily and rapidly with a packing, but after the surgery, immediately after the surgery, we performed angiography showing a stenosis of the vertebral artery at the V1 and V2 segment junction, but no active bleeding, and there was no ischemia on the posterior fossa on the MRI. Angiography was repeated at day 2 and 1 week, showing the improvement of the stenosis, but the appearance of a pseudoaneurysm, estimated at 1 week around 5-6 millimeters. And a new angiography was realized 2 weeks after the surgery, showing the progression of the pseudoaneurysm, now estimated around 1 centimeter. So it was decided to treat it and to perform a stenting with flow diverter technology. And this is the CT scan at 3 months, showing the good progression of bone healing and bone consolidation at the site of the osteotomy with no mechanical complication. And at the end, the patient was happy with the surgery, with a recovery of the horizontal gaze and a strong reduction of neck pain. So finally, thank you so much to you, Professor Georges. You make us able to perform that kind of surgery. It was a chance and a great honor to learn from you. And as said by Sébastien 2 weeks ago in Paris, you made us better surgeon for sure, but also better person. Thank you so much.
Thank you, Cédric. Nice talk and impressive cases. It's maybe we can discuss at the end if you would like some aspects. Now it's for me a pleasure to invite Jan Frederick Cornelius to speak about osseous tumors at the cranio-cervical junction. Jan, tell me if I am wrong, but I think you are the one who spent the longest time with Bernard Georges at that time in Paris before you moved to Germany.
Yes, thank you very much, Michael, for organizing this this common conference. And yes, it means very much to me too, and it's a very honor and a pleasure to to share some of his ideas. And in fact, yes, I think I spent the first time I learned to know him, the first time I saw him was actually when I was a medical student, 1994. And then 6 years later, I went to Paris and started my residency, and then stayed for 10 years with him. So I'm very was emotionally struck when I learned the bad news 2 weeks ago. Sebastian called me and told me, and so we had the chance to say goodbye at La Rivière 2 weeks ago. So this was also very nice to meet again with all the colleagues and disciples. And so, well, Bernard George was a great neurosurgeon, and I think his name is, like Michael said, undissociated from the words skull-base surgery, vertebral artery, La Rivière, and he got his an achievement for his lifetime work in 2008 with the Oliver Kroner Award. But he was also as a man, he was great inspiration and a person, an example to follow. So when he was young, he was going to learn from the best, Spätzler, and here with Majid Sami and Alain Coquart. And later he gave us the knowledge which we share today with you. And even this was in 2018 when he was already very sick and ill, but he still came to the courses and gave his lectures with very much enthusiasm. So talking about the CRANIO-CERVICAL junction, so he said that dealing with the CRANIO-CERVICAL junction pathology, one must be able to apply any of the main surgical approaches. And this is an article which resumes pretty much of his experience, and it's a very rare entity, the bone tumors, that I'm going to speak of. And Professor Bertalanffy in his review said that this obviously constitutes the largest single center patient series, and that he has no doubt that Dr. Bernard George has the greatest experience with this specific exposure worldwide. So everything is derived from this thinking. So it's a complex region with important neurovascular structures, and there are also ligamentous elements which achieve as well the mobility as the stability. And there are a lot of pathologies, and the goal must be a radical treatment as possible, but with preservation or restoration of the stability of the CRANIO-CERVICAL junction and with minimal morbidity. So when looking at the tumors, so we have the intradural pathologies, and I know that Oscar Alves is going to talk about the intradural pathologies, and we have the extradural tumors, which are constituted by chordomas, which will be treated by Sebastian, and we have the primary bone tumors. So the bone tumors and chordomas are by far less frequent than the intradural tumors, meningiomas and neurinomas. And however, they have a very wide variety. So there are, roughly speaking, the benign and the malignant variants, but very, very many subtypes. And so when looking at some examples, you get the metastasis and the chordomas. But then you have a lot of primary bone tumors like the osteochondromas, the aneurysmal bone cysts, osteoblastomas. And here's another specimen of an aneurysmal bone cyst huge and involving all the cranio-cervical junction. Then you have osteoid, osteomas, fibrous dysplasia, histiocytosis, but you also have pseudotumors like synovial cysts or degenerative pathologies or tuberculosis or rheumatoid arthritis or even bony malformations. So when dealing with a tumor of the bone tumor of the cranio-cervical junction, this should raise some questions. One of the first is if you're dealing with a benign or a malignant pathology, and then in some instances a biopsy may be helpful to orient the further treatment. Then you have to do an accurate preoperative imaging to look at the extension to the adjacent structures, maybe consider revascularization, and of course you have to judge the stability of the cranio-cervical junction. And then you have to fix or set your surgical goal. So if you want to do a radical resection or a partial resection, depending on the species, the entity, and which complementary treatments may follow. So the definition that he had of the cranio-cervical junction was that you have two parts. You have the lower part of the intracranial cavity with the lower clivus anteriorly and the occipital condyles laterally and the posterior margin of the foramen magnum posteriorly. And you have the other part, which is the upper part of the cervical spine with the atlas and the axis. So you have, if you look on the right, you have the C0, C1, and C2 parts of the vertebrae, and that constitutes the what you call the so-called lateral wall. And as opposed to the lower cervical spine, the C1 and the C2 roots emerge behind the joints, and laterally of the C1, C2 joint, you have the vertebral artery. So this was already mentioned. It's the relationship of the vertebral artery at the C1, C2 level during head rotation. So this has to be considered if you install your patient, and this may change completely the trajectory of the vertebral artery. So I was speaking of the walls. So there is an anterior wall, which is formed by the clivus, the anterior arch of the atlas, and the anterior part of C2. And this may be reached by the transoral or transnasal approach. Then you have the lateral wall, which is formed by the C0, C1 and the C1, C2 joint, and may be reached by the two lateral approaches, which I will develop. And you have the posterior wall, which is formed by the occipital bone and the posterior part of the atlas. So this posterior wall is very weak and does not really participate in mobility and stability, and may be reached by a standard posterior midline approach. So, but the lateral approaches, these are designed to reach the lateral wall of the cranio-cervical junction. So as I explained, it's formed by the CO, C1 and the C1, C2 joints. And either you come from posteriorly, then he coined this the posterolateral approach, or you come straight laterally and then may even go anteriorly or posteriorly. And this was called the anterolateral approach. So, and one of the main purposes of the anterolateral approach is for bone tumors of the anterior and the lateral wall. So this is the positioning. So for the anterolateral approach, the patient is in a supine position. The head is slightly extended and rotated to the contralateral side. And as mentioned, you have to be aware of the way the vertebral artery course is modified at the C1 and C2 level during this maneuver. And then one key point or key step is to open the field between the jugular vein and the sternocleidomastoid muscle, and to protect the accessory nerve by wrapping around the fat head. So these are some steps further, and at the end it allows by transposition of the vertebral artery to reach the C1, C2 area laterally and even go in front of the neuraxis. So when considering the instability, he always said that instability is a preoperative problem and not a postoperative problem. And what did he mean by that? He meant that you have to decide in front of or before surgery if there is if a stabilization procedure is necessary or not. And then you have to plan either in the same or in a different step. And his dogma was that if the lateral wall was intact preoperatively, it had to remain intact also postoperatively. So he had a very large series of bone tumors, and as you can see here, he had grafting or fixation in about only 25% of the cases. So there were two possibilities to do the to restore stability. One was what he called the lateral graft. So a piece of iliac bone graft was harvested and then implanted between the body of C2 and the upper lateral wall. This may fit, for example, for a unilateral disease, and if there was a bigger defect of the anterior or also the anterior and lateral wall or both lateral walls, then you had to consider a posterior CRANIO-CERVICAL fixation. And then there is the posterolateral approach, as will be developed by Oscar. It's mainly used or useful for intradural tumors, but may also be useful for extradural tumors at the lateral wall of the CRANIO-CERVICAL junction, but with a posterior epicentrum. So here briefly for the posterolateral approach, the patient is either positioned in a supine position or in a sitting position. Professor George liked very much the sitting position, and then you had a midline incision or a hockey stick incision to the mastoid. And then one key element of dissection at the upper border of the arch of Atlas, you had to perform a subperiosteal dissection of the vertebral artery, not to hurt or injure the periosteal sheath, as Michael told you. So this was the main step here in this approach. So yeah. To resume a bit what I was saying, so when doing surgery around the CRANIO-CERVICAL junction, you had to do your image workup. Then, very important, respect the lateral wall. Then key point was dissection and control of the vertebral artery. And then you had to opt for the adequate approach. So either a simple posterior approach, an anterior approach, or one of the lateral approaches. So considering morbidity, he always claimed that this should be minimal and vertebral artery injury should remain an exception. And if the artery was englobed by the tumor, as Michael explained, you had to consider the vertebral artery sizes and perform a ballon occlusion test, and if the ballon occlusion test failed and sacrifice of the artery was still necessary or planned, then you had to prepare for a revascularization procedure. So the other nerve elements were that were exposed were the accessory nerve by retraction of the sternocleidomastoid muscle, and exceptionally also a lesion or to the sympathetic trunk, leading to a Horner syndrome, and other nerves were the caudal cranial nerves, which were exposed if you went in direction of the foramen ugularum. So here are some of the cases or examples, and these are all the slides with the blue background are from his presentations. So these are his patients that he treated, and so I will just go through some of them here: aneurysmal cyst, metastasis, osteoblastoma, fibrous dysplasia, histiocytosis, osteochondroma, then very extensive chordomas, sometimes requiring combined approaches, even combined bilateral anterolateral approaches. So yeah, apprenticeship for cranio-cervical junction surgery was very long, and it requires a lot of technical skills from skull-based surgery, vascular bypass, complex spine surgery, knowledge of interventional neuroradiology, handling of the endoscope, the intraoperative monitoring, spinal navigation. So these are all things that I've learned, and this is a photo on the right. It was my last day at Lariboisière Hospital, and I left with a laughing eye and a crying eye, because of course the time I spent there was very intensive, and I think he made up everything that I am as a surgeon. And the jingle that you just heard is the SNCF jingle. It's the main train station. Gare du Nord is very close to Lariboisière Hospital, and I heard this jingle over and over 10 years. Every night I was on call, so it still makes go up my adrenaline if I heard it. So what did I take home? So surgery is anatomy, anatomy, anatomy. The technique has to be clean, bloodless, and accurate. You have to team up with your colleagues from neuroradiology, ENT, plastic surgery. The mindset is you have to achieve your goal and never give up. And your spirit, you should be open for new technologies and other techniques, and go and watch other people working. And as a man, to be punctual and precise, and also life out of hospital. So work hard, but also carpe diem. And when going back to Düsseldorf, we continued working on the cranio-cervical junction and these bone tumors. And this was in 2017. So he came to Düsseldorf, sorry, and we had a very nice course, and he was giving us his lecture about the cranio-cervical junction. So what you should take home: so cranio-cervical junction bone tumors, there's a great variety of tumors. The metastasis and the chordomas are the most common, followed by primary bone tumors, but there may also be pseudotumors. So you have to consider this in your preoperative planning. Surgery, you have one or several approaches, one or several stages. You have to respect the lateral wall, and the key point of surgery is, of course, the vertebral artery. You should always try to achieve a complete resection with limited morbidity. And so I'm at the end of my talk, and I thank you for listening, and thank you for your attention. And I thank Professor George for everything that he gave us. Thank you very much.
Thank you so much, Jan. It's now time to move to Portugal. It's a pleasure to welcome you, Oscar. Oscar Alves will discuss with us the intradural tumors at the level of the cranio-cervical junction. Please, Oscar, up to you.
Thank you, Michael, for and DNS for putting together this tribute to our mentor. I would like to share my screen. If,
Jan, you have maybe to start to share your screen.
Sorry.
Please, Oscar, to you.
okay, so once again, I would like to thank Mikhail and thank the words of Mikhail and Jan. I cannot say better than what you said about our mentor. And I think today we have kind of mixed feelings. We are smashed by this loss, the loss of our mentor, but in a way happy, joy, because we have the notion that he influenced many of his disciples, and that his words will prevail over the years due to his publications and to his fellows. I start to know Bernard George on the turning of the century, when I became his assistant professor in Paris, and actually I was going for my first professional experience as a neurosurgeon, looking for vertebral artery, but I end up finding my mentor, my master, and also a very good friend. As Bernard used to say, operating on the brain, especially on the cranio-vertebral junction, is like riding a Formula One car. You have to be aware of all the possibilities, all the problems that might arise, and always act before problems arise. So when you want to work in this area, you have to be aware of the cranio-vertebral junction anomalies. There are plenty of them with embryological origin, and you can have, like, for example, the atlas, complete assimilation of the atlas aplasia, which are situations that are unstable. Probably the most frequent is foramen arcuale persistence. It can reach almost 1/3 of the cases in some series, and it can mistake you by a broad, widened arch of the atlas, which really is not the case, and you can damage the vertebral artery if you don't pay attention to this anatomical variegation. And of course, you cannot insert hooks or a pedicle screw in C1 if you face this situation. Sometimes it's the pathology that can induce changes and change the landmarks of your surgery, like the paradigm is rheumatoid arthritis, as you see here, different examples of changes. The anatomy of this area is really rich. And if you pay attention, the C1 mean inner AP diameter is a little bit over 3 centimeters, which is the double of the spinal cord, which means there is a mismatch between the canal and the contents, and there is a generous space which allows for the silent growth of tumors. So clinical presentation always, most of the times, comes very late in the development of the tumor. So prepare to deal with rather big tumors, but they will create the corridor for you. It will make it easier surgery. You have to know the intricate neurovascular anatomy of this region, and one of the first things I learned with Bernard was the solid knowledge of the cranio-vertebral junction, surgical anatomy, or whatever region you are operating in the brain. As it has been said before, vertebral arteries, only 40% are equal. Both small sizes and common. Be aware of the persistent congenital anastomosis between the vertebral artery and the carotid artery, being the congenital the most significant one. And suspect always of vertebral artery modified course, especially when there is bone malformation. Persistent first intersegmental artery, as you see here, as it has been shown before, extracranial origin of pica, C1, C2 level, and many cases of fenestration of the V3 segment of the vertebral artery. If you do instrumentations like we do sometimes at C1 level, this is the entry point for your screw. This is really close to the vertebral artery, so you have to do a meticulous and bloodless dissection of the CT nerve root, and I advise you to do it under microscope. If you do an instrumentation in C2, you have to consider this superior and middle loop of the vertebral artery under the facet, and this can happen on almost in 1/4 of the patients. There is a high risk of vertebral artery injury because there is a reduction of the isthmus height and an internal height of the lateral mass. And as you see here, this raises a particular problem when you instrument in this area. There are many variations of the vertebral artery loops and pedicles that you have to be aware before doing your surgery. And in some cases, you even need to mobilize the vertebral artery to be able to insert a C2 screw, as you see in this case. So all the surgery, the crucial element of the surgery around the craniovertebral junction is the vertebral artery. Vertebral artery, as you see here, has multiple loops, and the surgeon can take advantage of those loops to mobilize the artery away from the pathology, here from the groove, here from the C1 transverse process, and we still open and highway for the tumor. As Professor George would like to say, like in a battlefield, you have to know where your enemy is since the beginning, not at the end of surgery. You will end up not being perfect and inducing morbidity. As it has been said before, the head positioning can change the vertebral artery position. Here, contralateral rotation of the head for the final surgical position from a bayonet shape to a U-shaped vertebral artery. And this happens to preserve blood flow. The key maneuver, and we've owned this to Bernard George, is the so-called supraosteal dissection. There is a venous plexus that surrounds the vertebral artery, and both the plexus and the vertebral artery are enclosed by a supraosteal sheath that is continuous with periosteum of the transverse foramina and the dura mater, the posterior fossa. And the vertebral artery is free mobile within this supraosteal sheath. So if you maximize your dissection and you are delicate enough with supraosteal dissection, you can mobilize and control the vertebral artery with major risk of the artery. However, some venous bleeding is expectable that you can tamponate or even regulate. Not always this can happen because the paradigm of lesions that can invade supraosteal sheath is osteocytosis, and sometimes neurinomas and angiomas, they can also occlude the vertebral artery. Conceptually, you can approach this region, the craniovertebral junction, from 180 anterior, transnasal, transoral, the anterolateral approach for extradural anterolateral tumors, for oblique pectomies, the posterolateral approach for intradural tumors that I will talk about, and the classical posterior midline approach. So the secret of this lateral approaches is really mobilization of the vertebral artery and minimal bone drilling to preserve stability. So no need for stabilization in most of your cases. Intradural tumors of this region are immense, diverse. Meningiomas are the most important. Only 4% are extradural. Neurinomas, more than 1/3 can be intra and extradural, or just to say that one third are purely extradural. But you can have epidermoid, melanoma, meningioblastomas, ependinomas in this region. You know, nowadays we all talk about vertebral artery mobilization, but when I started neurosurgery, this was really the scenario. It seems now very easy to do and very, you know, like not astonishing to do this kind of mobilization. But in those days, this was the vision of the surgeon. Very limited midline approach, and the medial age of the horizontal part of the 3-3 segment along the arch of C1 is around 10 to 32 millimeters, mean of 25 millimeters of midline. And this was really a very limited amount of exposure with a need to retract the spinal cord, inducing problems and morbidity. So by mobilizing the vertebral artery from the arch, the lateral part of the arch of C1, where there is a little step here, you can widely increase your approach. And another very important anatomical detail, if you see here, if you draw a line from the posterior aspect of the lateral mass of C1 and condyle, you see that the neuroaxis is all posterior to this line. So, and this is in contrast with subaxial C-spine. So very little condyle drilling or instrumentation are required when you're drilling with intradural tumors, even if they are anteriorly located. This is the approach. There is a variability in height and extent of this groove of C1. Sometimes be aware that the vertebral artery can enter below C1, and this can be very tricky. The extent of drilling laterally, it's really dictated by the location of the tumor. Once you have done your craniotomy, exposure of C1, drilling of C1, you can open the dura and you do then this kind of incision and a counter incision towards the vertebral artery entry point. It's very important that you appreciate the relation of the tumor with the vertebral artery. It can be below the vertebral artery, it can be above or on both sides of the vertebral artery. So mobilizing the vertebral artery above or below will allow drilling of bone enough to expose the lesion. And the tumor is located below the vertebral artery. Very likely the cranial nerves are displaced superiorly away from the tumor, and this will make your surgery much more easier. If the tumor is above the vertebral artery or above and below, this is more difficult scenario, and the location of the cranial nerves is unpredictable. You probably have to do both to some extent first, and then control the caps of the tumor and work like this. Lateral location tumors, extradural exposure with limited drilling of the condyle and lateral muscle C1 is enough. If you have an anterior located tumor, you better work on both sides and you'll be able to remove the tumor completely. So this is just my personal series from 98 to this year. Surgical mortality is no mortality, complete recession, and very low morbidity. And this is really the great teach of Bernard George, that we were able to replicate his teaching all over the world and for the good of the patients. Different kinds of intradural tumor, pre and post-operatively, as you see here. So in conclusion, there are many tumors in this region, meningioma being the most common. Preoperative planning accounting for congenital and vascular anomalies is key, as it is of most importance to control and mobilize the vertebral artery, as Bernard George showed us that this is possible. Respect the lateral wall and no need for stabilization. And I would really like to thank this again, Mikhail, for bringing us together. And as he said, Bernard George was a master, a mentor, and of course, a friend. And back to all my career, he was really the key element. I could identify that the most influential person on my personal career, not only because of vertebral artery, but I learned from him. And I'm very happy that we are here today. And I think in a couple of hours also, CNS is paying tribute in the US to Bernard George. Thank you.
Thank you so much, Oscar. Very interesting your talk. We move on now to the talk of Damien Bresson. Damien, you have worked with Professor Bernard George for a long time also. And so we will listen with pleasure to you on the tumor he also mastered. Please.
Thank you very much, Michael. And once again, thank you for the opportunity to share what we learned from Bernard George. And as you said, I've spent a few years working with Bernard George, with you also, and with Jan Cornelius, Sebastian Fröhlich, Oscar Luis Alves. So it's a really great pleasure and a little bit quite emotional as well that I speak tonight. So Bernard George was a wonderful surgeon for the vertebral artery. He was also very talented and an amazing surgeon for skull base. He was both a great visionary and a mentor, and he dedicated his life to its patient, neurosurgery. So this is the other aspect. You showed a beautiful picture of him working. This is Bernard Georges when having a rest during lunch. And at that time, he didn't read the vertebral artery, but he was reading a sport magazine, L'équipe, because as you may know, his dream was to be a journalist in sport. And he finally decided to be a neurosurgeon, but he was very interested in sport all his life. And he saw himself like a pilot of Formula One with a goal to be very concentrated to achieve one objective, that is to win or to resect the tumor for the best of the patient. And of course, he worked hard, and he learned, he taught us how to avoid complication, how a good planning could prevent any complication. And he had few. He was very talented, but he had few, and he was also very honest when talking about its complication. And we learned a lot also with these issues. So his career, as you said, is closely linked to the Hôpital Lariboisière. His department is, of course, the Department of Neurosurgery. This is a picture of Claude Lorient, a vascular surgeon, with whom he wrote the first book of the vertebral artery. And this is Professor Houdard and Philippe Herman, interventional neuroradiologist at ENT. And Bernard Georges was closely working as a collaborative work with all these colleagues. This is the different fellows. You may notice, you may know some of them: Yann Cornelius, Oscar Ruiz-Alves, Radbaot, Emmanuel Mondonnet, Michael Bruno, Cédric Barré, but also Sébastien Mounet and others. He was also close to the nurse, and it was very important to, as Jan said, carpe diem, to enjoy after a good day of work. And we had many of these events to make some team building and to share after hard day working. Just a few words about his vision. He was a visionary for two main techniques. He was visionary for the endovascular treatment of the aneurysm. He decided to decrease and to favor the intravascular embolization in the 90s. And in fact, the study, the international study Lancet, showed that it was better to embolize the aneurysms when ruptured. And in this specific field of vascular, I did for the benefit of the patient to refer the patient to the endovascular therapy. So this is, in that sense, he was a visionary. Of course, he was also a visionary for skull-base lesion. I show you a few examples of this lesion. These are chondrosarcomas and chordomas that he dealt a lot, and that we dealt a lot with him in Lariboisière. But there is also many, much more tumor like meningioma and schwannoma. So as you may know, there are different surgical strategy and different approaches. There are the lateral approaches, the anterior approaches like the subtemporal Kawase approaches and the posterior-lateral approaches. They may be combined, for example, the combined transpetrous approach, but there is also the endonasal endoscopic approach 2007. Can you hear me? Because I've got some issue with my connection. Is it okay? Michael?
Yes, it's okay.
We can hear you.
Yes.
Okay, thank you. So the purpose is not to say that there is one approach better than the other, but there is also one tumor with its own behavior, biological behavior, its own extension, and so you have to decide the best way to tackle the tumor, and you have to, in that sense, you have to be not limited by the technical aspect, and you have to be able to do a classical approach, but also endonasal endoscopic approaches. So he was also a visionary for these endonasal endoscopic approaches, because as he was doing a lot of chordomas, and as chordomas are midline and extradural tumor, it was it made sense to operate such chordomas through an endoscopic endonasal approaches. So despite that he liked to anterolateral approach and the classical transcranial approach, he referred some of them and to the endoscopic endonasal technique. And this big surgery starts in Lariboisière around 2007, and 2 years later we had the opportunity, again because of the Bernard Georges connection and friendship, to have Professor Kassam and Professor Carrao to operate and to be in Paris, and so that we were able to make a workshop for endoscopic endonasal surgery. This is Philippe Hermand that you may have seen also. So Bernard Georges was very attached to make a very good clinical assessment, not only pre but also post-operatively, and he was following his patient a long time after. Important to make a good imaging workout with CT, angio-CT, MR, different sequences, and angiography if necessary. The objective was to have an hypothetical diagnosis for the biological behavior of the suspected tumor, and to envision the tumoral development of the tumor from its origin, the epicenter, and to see, to follow the pathology and to be able to detect the nerves and the vascular structure that could be shifted around the tumor. So he was insisting of doing a very meticulous pre-planning to choose the most appropriate approaches, or once again, combination of approaches. Maybe such tumor, a specific tumor, may have two-stage surgery to be removed. And the goal was to achieve the best reduction, to improve the prognosis of the pathology, and of course to respect the parenchymal and vascular nervous elements to preserve the function. Of course, he was insisting on the fact that surgery was a tool, but there was also some other tool like chemotherapy and radiation therapy. So he taught us the basic rule for skull-based surgery, to resect bone but not brain, to give priority to functional results, and to decide for less invasive approach on case-by-case basis, either a single modality, either combined, depending on the tumor. Before going in the OR, of course, and as everybody said, you have to work hard, and he learned us to work hard, because what I learned also from Bernard George is not to schedule anything in the night, because you will spend hours and hours in the OR. You may perform some dissection of specimen, reading. You may learn and read, and of course practice and perform your first surgery with a mentor or a master. In the OR, he was very rigorous, and he was saying in French, comment fait ce lit, on se couche. When you have made your bed, now you must lie in it. So that is to say that if there is hyper intracranial pressure because of the anormal venous drainage, because of the malpositioning, it would be his fault and no other's fault. We learn about indications. For example, when we start endonasal endoscopic, this is an example of olfactojugal meningiomas. At the beginning of the endoscopy, lots of publications were performed to remove those meningiomas through the endonasal endoscopic route. And we thought in Oribasia that it was a nonsense, because when they are huge, the lateral aspect of the meningioma is far away the parasagittal plane going through the optic nerve, and where you won't be able to remove this lesion from an endonasal route. And if there are some small meningiomas, usually the olfaction is still present, and osteomeningioma, you will impair definitively the olfaction. So we decided long time ago not to operate those meningioma through the endonasal endoscopic route. And again, we don't approach them through bilateral bifrontal craniotomy. A unilateral craniotomy and a subfrontal approach, avoiding to open the frontal sinuses, is usually fine to tackle any kind and to remove any kind of anterior skull-based meningioma, and to be able to preserve at least one olfactive bulb. This is an example of small craniotomy to remove a large olfactojugal meningioma. For jugal meningioma, you may have a different surgical option through diagonal approaches or through eyebrow approaches. This is the keyhole concept. No matter the entrance, what is more important is that you preserve the brain and the vascular nervous structure. And I learned, for example, in Bernard George, for this case of a small meningioma, jugal meningioma, leading to visual deficit of the left eye, I learned to approach this meningioma through the opposite route, which is much more safer for the optic nerve. So for this, in this example, of the left side meningioma, the approach should be done and has been done through the right side, through the contralateral right side. Again, he was very open-minded, and with the endoscopic endonasal area, we were willing to remove and to approach a tumor that are growing below the plane of the optic chiasma. And this is more logical because if you want to remove a tumor who develop below the optic chiasma, it's much more logical to go from below to avoid any damage and any manipulation of the optic nerve and the optic chiasma, for example, as we used to for a craniopharyngioma in the optico-carotid recess. This is an example of meningioma that has been removed by an endonasal endoscopic route in 2008. Much larger tumor for skull base. And of course, looking at the coronal view, you may want to have more ascending approaches. And so for this patient, an orbitozygomatic approach that will give you a more ascending trajectory will be more safe to preserve the left temporal and frontal lobe. Again, it was and told us that the main aspect of the of our indication is to preserve the function and the quality of life of patients. So whenever there was a remnant, we were having some multidisciplinary meeting with the radiotherapist to discuss about postoperative irradiation on a remnant. An example of a man who was 76 years old with only a trigeminal neuralgia and the first magnetic resonance imaging showing a petrodontal meningioma with the compression. The patient was unwilling because of its age to be operated. And so he was put only under carbamazepine, which cured the neuralgia, and then it was followed up. This is a follow-up MR showing an enlargement of the tumor, and finally, because of this growth tumor, the removal was decided. This is the postoperative removal, and there was a small remnant attached at the lateral aspect of the brainstem. Beam therapy because it was a grade 2 meningioma. Again, an example of a petroclival meningioma that was removed from combined anterior and posterior petrosectomy with a small remnant at the lower CRANIO-CERVICAL junction, and the patient was sent to proton therapy. So in Lariboisière, we used to see those big tumor, and thanks to Bernard George, we are able to manage this kind of tumor. So this is a huge chondrosarcoma, and you may see the internal carotid artery, which is inside the tumor on the right side, but also on the left side. So this tumor is not so easy to manage, and we decided first to make a midline endonasal endoscopic approach to decompress the left internal carotid artery and to remove the medial part of the tumor, as you may see on this CT scan. And then 6 months later, we made a balloon occlusion test. We interrupt the internal carotid artery and we remove the tumor through a lateral classical approach. And this is the final view of the patient, showing a nearly complete removal before radiation therapy. It was a chondrosarcoma. So Bernard Georges is still present in every practice, of course, in the ER. What I learned is to work hard, to be familiar with all the technique, to make good preoperative. As Isaac Newton said, if I have giants, and thank you, Bernard George, for being my giant.
Nice
Thank
conclusion.
you. Thank you very much.
Nice conclusion, Damien. It's now time to move to listen Sébastien Fröhlich. Sébastien, you moved from Strasbourg to Paris, an incredible challenge to take the position of Bernard Georges. I think you succeed to maintain the level of the department at the highest level in the world, I think. So it will be a pleasure to listen to you and share with us your experience and the Bernard Georges experience on chordomas. Please, Sébastien. You are muted, Sébastien, I think.
Yes. Thank you, Michael, and thank you for putting this this webinar and being all together. It's very nice to see all those souvenirs and pictures from Bernard. So the topic you asked me to cover is chordoma, what we have learned from Bernard. The answer for me, in fact, is everything, because when I arrived in Lariboisière, I had absolutely no clue about chordoma. I did maybe 1 or 2 cases in Strasbourg, and definitely Bernard had amazing knowledge, a feeling of the disease. He treated so many patients that when he was seeing a patient in office, building a strategy, it was crystal clear for him. It took me a while, and I guess for all of you, it took also a while to get this feeling. But Bernard was one of the person in the world, I guess, who had the highest knowledge of the disease, not only the technique, but really the disease. And so I learned everything from him. He was an outstanding teacher. And when we look at the picture of him, it's interesting to see that most of the pictures that we have are coming from courses or lectures that he gave all around. He was a fantastic surgeon, but he loved to teach. And that's what he did with all of us. And when he was in a course, he was like 20 or 30 years ago when he started, with the same, absolutely same energy and willing to show and to transmit to people. This is when I arrived in 10 years ago. It's amazing how time is running. So I was very young, and he was already not at the end of his career, but not so far. And it was absolutely fantastic working with him for those few years. We get along very well, and it completely changed my career. So about chordoma, it was really one of the diseases he was the most comfortable with. And he dedicated a lot to chordoma. He spoke, he taught a lot, he wrote a lot, and he wrote this report in 2013 in neurochirurgy. It was a little bit after I came, and I was brought into this dynamic of building this kind of Bible about chordoma. And this is also where I learned, looking at Damien, at all the team. It's really something I discovered, because everybody, the team, tumor board, radiation oncologists were dedicated to treat this disease. The experience we have now is significant. I just took over, which means that patients were referred to him for a very long time. And yes, I tried as much as I could to keep going with this heritage that he gave us. One of the things he was saying in the OR is that c'est pas moi qui suis agressif, c'est la tumeur. And yes, he was a fighter for chordoma. And when he was in the OR, this is something I was rapidly surprised of. He was really fighting. Surgery was not easy for him. We all know that he was quite sick, and it was a fight to stand up for so many hours. But he was fighting for the patient first. And when there was a little piece of tumor that he was feeling was a little bit beyond what was visible, he was going to this piece of tumor. And nobody better than him knew without seeing it that 1 centimeter further, there was a little piece of chordoma between 2 layers of dura. So this is what I learned from him, rapidly fighting to get the last piece of tumor, because it's not us who are aggressive, but the chordoma himself is aggressive. And this is what I got from his experience, that extent of resection for chordoma is extremely important. This was one of the main pieces of information that he brought from his experience in this report of neurochirurgy. This is an example of a case of a chordoma. You see tumor here in the petrous apex. You see here tumor in the area of the jugular tubercle. You go down, there is tumors in front of the arch of C1 along the odontoid process, behind lateral mass of C1, and it's going down. It keeps going down around the Batson venous plexuses, between layers of dura here behind the lateral mass of C2 and foramen of C3. So you understand that in a case like this, if you don't have a clear strategy looking after all those pieces of tumor with 1 or 2 surgeries, or at least an approach that can expose all these areas, you have no chance to take all these tumor out. And when you're in, you need a plan and to look for all those pieces of tumor. And this is really something that you need to fight for this. And it's definitely something I learned from him. As Damien said it, we are doing proton beam therapy for almost all our cases. But this is something also that I learned from Bernanrd. The strategy we are proposing to the patient is not optimum, because it's a very heterogeneous tumor. You have rapidly growing tumors like this one. We did not so long after I arrived. This patient came with this chordoma in the sphenoid sinus. I did surgery on her, and rapidly after, the tumor came back. She was treated with radiation, and she benefited much more from proton beam therapy than from my surgery, in fact. She survived a little bit more than 2 years after proton beam therapy. This is a patient that came 25 years after seeing Bernanrd in office for a diplopia. And at that time, he had a CT scan. I'm not completely sure he had an MRI, but he had a tumor in the area of the petrous apex Dorellos canal, and he was lost for follow-up because the patient didn't want to have a biopsy and a surgery. And he came back 25 years after a nice life without any issue, until he got new symptoms, 6 nerve, and also sign of compression of the brainstem. So here, this patient was close to 70. We decided not to have an aggressive strategy, surgery. I did an endoscopic endonasal approach, leaving a kind of carpet of tumor, and he was fine for 3 years. But unfortunately, it was not necessarily a good idea not to give him proton beam therapy, because in fact, he recurred, the tumor came back much faster than it grows the first time. Another lesson is that, yes, it's an heterogeneous tumor, but during its lifetime, this tumor can change in terms of biology. One thing I learned also, because most of the patients we had were patients referred from other centers with previous surgery. And this is something we figure out rapidly, looking at our data with Damien, our endoscopic endonasal data, is that when a patient was treated before in another institution for a biopsy or partial resection, he was losing some chances, because achieving a complete resection once a patient has been previously operated is much more difficult, especially for endoscopic endonasal, because you have scar tissue, because you don't have the landmarks, and because it's more difficult to close. So the amount of resection is lower, and necessarily survival, progression-free survival, overall survival is not as good. So what was missing, and what is still missing for Bernard, but for us also, is prognosis factors. Prognosis factor before going to surgery, prognosis factors coming from the analysis of the tumors. There is publication coming on this, and Bernard was pushing strongly for basic research. And I remember, Damien will probably remember also, when he wrote this report in 2014, he was not a scientist, but he went really deep into the subject, trying to understand the molecular biology behind chordoma, the tyrosine kinase, and all of this. And he was talking about it quite often, really trying to understand what was behind. And it was typical of Bernard, a strong curiosity for new stuff, new things, new technique. And he was a strong believer in the future and in us also achieving what he was missing during his career. So there is papers coming for those prognosis factors. We have published this recently, looking just at the growth rate of those chordoma before surgery, to see if this growth rate is related to the aggressiveness of the tumor, and it is. It's very simple to do, and it can give you a piece of information to adjust the aggressiveness of the treatment. There is more complex prognosis factors, such as the methylation profile. This paper just came out. It's a study we have done with Toronto, Gelarezadeh. That is, I think there is a lot of hope in those techniques, that we will be able, before deciding for surgery, to adjust the treatment strategy to the aggressiveness of the tumor. Surgery is tough for the patient. Radiation therapy, proton beam is tough, and probably that it's not necessary for every patient, and probably that for some of them, it's useless because the tumor is too aggressive. Bernard teach me how to work with a team, because he brought around him the people he needed to achieve the best result for the patient. ENT surgeon, radiation oncologist, having tumor board meetings, and the research network around him. And this is something I was not so used to when I was in Strasbourg, where I was mainly working for myself and not necessarily working as a team. I learned it sometimes the hard way, but it's really something that Bernard was pushing me for, pushing us for. He was a fantastic teacher, as I said, and from the early beginning of his career, he took as a priority to train the next generation, and this is not so easy. And you guys, I don't know if you have the same feelings, but time is running, and we are getting to close to 50, 55, and it's coming fast. And I think that if we have to learn something from Bernard, is to know that we are probably reaching the edge of our career, and we have to think already to the next generation, to the young guys coming behind us, and to make their life easy for them to be better than what we are. And this was the main goal of Bernard pushing us. He was proud of what we did, all of us, what we achieved. And I think we have to try to do the same for the young guys. This is what he would be happy of. Approach selection was important. This is exactly why I came to Lariboisière. This is really the reason why I came, this picture, because I was interested and I had a passion for skull base already. But I knew that here in Lariboisière, I would be able to learn what I was missing. Vertebral artery, jugular foramen, cranio-cervical junction. I had some idea and I was interested with already cavernous sinus transpetrosal approach, but there was no better place to understand the jugular foramen, the vertebral artery, and the cranio-cervical junction. And it was a time already where endoscopic endonasal technique were already quite developed here in Lariboisière compared to most of the places in France, including where I was in Strasbourg. So here it was a temple where all the techniques were put together to give the best chance to the patient. Bernard was a visionary, and he pushed endoscopic like nobody else. And Damien didn't say it, but maybe I'm wrong, but I heard these stories that when he started endoscopic endonasal, he was not operating. He was just behind Damien, looking at him, giving him some advice of what he was looking and of his experience of looking at this endoscopic anatomy from a transcranial perspective. But I think he never took the instruments for endoscopic endonasal approach. He was giving just the best he could to us, for us to improve fast. And this was exactly Bernard. I hope that in the future, I will be able to sit behind a young guy and to tell him, just go on, giving him some advice without putting too much pressure on him. So approach selection is something we are really thinking of here in Lariboisière, because what we can, the way we could change the prognosis for the patient and also the feeling of the patient after the surgery is by choosing the best approach and improving also our approaches, because the morbidity of the approach is sometimes significant. I like this picture a lot of Bernard with Kassam, with Damien, with all the guys after a course. I think it was a course just before I arrived in Lariboisière. And you see Bernard is really into it. He's at the same level than the other. He's into this new story of endoscopic endonasal. He did the same, yes, for vascular. Damien said it, and it's absolutely true. He's one of the first, I think, in France to have pushed endovascular technique. And Damien did a vascular fellowship in endovascular techniques for 4 years. And I think it's mainly because of Bernard, because Bernard was pushing us into this direction. Once he knew that it was best for the patient, that was it. So endoscopic endonasal is great, but what we have to think of is to try to reduce the morbidity of it. This is what we are trying to do here, to reduce the aggressiveness of the approach. Like any transcranial approach, there is always a time where we are pushing the limits, and there is a time where we have to step back to adjust the aggressiveness of our approach, to leave less footprint of our approach. And this is what we are doing here in Lariboisière, trying to be minimally invasive, like we did it coming from big open FTOZ approach to keyhole strategies. We have to do the same with endoscopic endonasal to have keyhole endoscopic endonasal approach. I go fast on this because just to say that this is what we are working on. And I think that Bernard was happy of us trying to improve this technique, not staying at the same level, keeping the same habits. It was not him. Every time he could look for something that would help him to improve his results, his technique, he was just looking after it. So this is a kind of a post-op MRI of a chordoma showing that the endoscopic endonasal anatomy, is quite the same compared to the preoperative MRI. I show you two cases to illustrate the strategies that we are trying to improve for chordoma. Big chordoma cases here, clival going into the cavernous sinus, young patient, almost asymptomatic, very slow growing tumor, but still she is young and it's a chordoma. So we need to treat, we need to do surgery. What is the best options? We thought about it. Endoscopic is possible, but when you list the amount of risk of complication with just an endoscopic endonasal approach, I thought it's too much. The goal is to keep the patient intact post-op, to leave as less as possible as footprints, to keep her intact, resecting completely the tumor. So we did two stages. This was endoscopic endonasal to remove everything that was extradural in this case, going one nostril, trying not to do a big endonasal resection of normal structures. It's a soft tumor. Chordoma is soft, so once you're in the tumor, most of the time it's quite easy. It's mainly a question of exposure, having access to all the corridors, the region of the tumor. But once you are on the tumor, the resection is not so difficult, except in recurrent cases. But in most cases, like this one that was very hyper T2, I knew that it would be quite easy once on the tumor. So working with angle, scope, malleable instruments, we were able to achieve a nice extradural resection, not opening the subarachnoid space, because if you do that, then you lose the advantages of combined endonasal transcranial. What I wanted to avoid, one of the things I wanted to avoid is to avoid CSF leakage. After 1 month, we do this MRI and we see that there is still significant tumor inside. Obviously, we left it in purpose. And here we decide to do a combined petrosal. You see that the tumor is going in multiple regions of the basal cistern, both sides going very high up, pushing the third nerve, which was very thin. If this patient has a third, because your suction going endoscopic sucks the third nerve, she loses the eye. So a third is much worse than a sixth. So here my goal was to have the best exposure possible and to preserve the cranial nerve. I cannot do that myself personally with the endoscope. I am much more comfortable doing it with a microscope and micro instruments. So this is the approach, combined petrosal, that we do quite often for petroclival. It's easier to do it for a chordoma because the bone is normal. Quite straightforward for a non-meningioma case. Opening of the dura is key because everything is in the mobilization of the sigmoid sinus, transverse sinus, that you push backward to have this corridor that goes below the temporal lobe. It's really a subtemporal approach without retraction. You use the volume of the mastoidectomy to have a direction coming from the back, down, up, lateral to medial. Here it's a classic micro dissection of the cranial nerve with multiple corridor. You have a corridor for the 6, a corridor for the 5, corridor for the 7, which give me much more confidence to resect this tumor. At the end, we put the endoscope inside to verify if the resection is complete. Can I guarantee a complete resection? This is very nice here, this picture. It shows you really the advantage of this technique. You can see the third ventricle from below. It's not so different from the view you have with an endoscopic endonasal with the mammillary body and the third ventricle. And this is why it's really an approach to the retro and fundibular region. So this patient, she had a 4 post-op, but she recovered after a few months. And I don't think I would have achieved this result with a purely endoscopic endonasal approach. So I think I will finish here. I will go to the end of my talk with my conclusion. This is really what I came here for. And Bernard really believed in this, and he pushed me in this direction, like all of us, to try to pick up everything we could to propose the best strategy to the patient. And this is definitely what is needed for chordoma. If you manage only one technique, then you have no choice. If you manage only transcranial approach, you lose the advantage of endoscopic endonasal. And now it doesn't make any sense to treat skull-based chordoma if you don't know how to do endoscopic endonasal technique. But it's not a reason to lose what he teaches us, antero-lateral approach for the cranio-cervical junction. And in fact, I step back for those techniques and I really use antero-lateral, postero-lateral approach strategies for skull-based cranio-cervical junction chordoma. I remember cases with Damien where we spend 12 hours, we did it, but it was a suffering and also a suffering from the patient. And the morbidity with the classic antero-lateral approach, which is a fantastic technique, is much less. So this was the picture you all showed. The last course we had all together, it was fantastic time. And Bernard was like he was 40 years old. And this was in IRCAD. Look at his face, looking at the dissection before starting. But he was also looking at the screen, looking at us, trying to learn, to push us, showing us that he was keeping learning from us. This was the last picture we wanted to send him before he left us. This is Pedro, the guy who worked in the cafeteria. Some of you know him. And this was also Bernard, because there was not a single week where Pedro didn't ask me, comment va Bernard? Comment il va? Passe-lui mon bonjour. And this strong relationship he was able to build with every one of us, every people in the hospital was also Bernard. So thank you very much to all of you for building this webinar. And let's keep going to give a tribute to Bernard by following his example. Thank you very much.
Thank you, Sébastien. In summary, Bernard Georges created around him a very nice family of neurosurgeons and friends. I was very happy to be with all of you this afternoon. I will just share, if you allow me a few seconds, one more video of Bernard. It's Bernard operating on one of his favorite topic as well. It's in case of ankle disc arthrosis. He developed the microforaminectomy technique, a very efficient technique. He always pushed the limits. I show you this video because it's typical of him. This video is a very special video. I was in his department at that time. I would like to publish the technique, and I need a video, but I don't find the video in his library. And I asked him, Professor Georges, I need a video for this publication. But the problem is he was no more in the department because he was treated for his first illness 1 month before. He was operated on the thoracotomy, and he was unable to work. To stand up was difficult. And he comes back to the department, and this is Professor Georges operating while being almost unable to work, to breathe, with pain. He was fighting against the illness, against the pain, but as you can see, his hand is perfect. He's doing the microforaminectomy, and is serving the patient. This patient is pain-free after the surgery. And Professor Georges dedicated all his life for his patient and to teach us what we try now to share with you. I will stop to share my screen. It was a very special video. You have to know the story behind this video, which is available on the neurosurgery website.
Yeah.
Behind this video, it is the true story of a man, fighter, pushing the limits. and achieving the goal.
Very nice story. I didn't know about that.
Yes.
Me neither.
So please, if you would like to say something more, difficult to say something more. I think many things have been said. It's
Just
our
to add that today there was also a tribute at the CNS Congress in Austin, Texas, and the tribute was nearly at the same time. So each side of the Atlantic, it's something extraordinary to speak about Bernard Georges all together. So that's
all over the world. These techniques will continue. Jan?
Yeah, I think it's meaningful that we are all joined here together and spending time for this webinar and sharing our thoughts and the concepts that he taught us. But we know it, each of us, that we have a very good friendship and that we meet regularly for congresses and have contact. So I think this is also something that what Sébastien was referring to, that he wanted to create like, yes, pupils, a group of pupils that were attached to him as a teacher, but also have a friendship and have like a connection between each other. And so I think we never were like in concurrence or whatever. So, but it has always been a very, yes, friendship, very collegial, and I think this is what he dedicated us to.
Something more to say? Would you like? Oscar, Radboud, Damien, Sébastien?
I think he should be where he is now, very proud of us. This was a really nice tribute for him. And, you know, I'm sure his work will endure over time because of us and the work we do and the work we can teach to future generations and pass this work to the ones who will come later. So once again, Michael, I really thank you for this tribute. That's awesome.
Yes, I agree. Thank you so much for organizing this, and let's stay together in some way.
Of course.
So it's time to leave you, but I'm sure that we will stay in contact as we were since a long time now. And for all people who were kind to attend this webinar, it's my pleasure to invite you to the next webinar that the ENS section give. And it is planned mid-November. This Wednesday, I will have a look on the exact date is 17 November. It will be a pleasure to be again with all of you. So guys, we keep in touch for sure.
Thank you again, Michael.
With pleasure.
Yeah. Thank you, everybody. Beautiful talks.
See you soon.
Bye-bye.
Bye.
Bye.
Yeah.
thank you.
Beautiful memories. Bye-bye.
Bye-bye.